Thank you very much. And I think we've just got an idea of how difficult it is to have a patient in front of you with elevated intraocular pressures, with PACG, and try to figure out what might be right for this patient actually. So trabeculectomy and lens extraction, as speakers before me have said, are a debate that refuses to subside. Lens extraction has been proven to reduce intraocular pressure in eyes with PACG, and combined surgery has been found to be slightly more effective in reducing intraocular pressure, as Shushmita also pointed out, but with somewhat greater complications actually. And therefore, should one do combined surgery at all, or restrict oneself to either glaucoma surgery or lens extraction actually? So I think we already have two proponents of trabeculectomy and lens extraction here with us, and we'd like to hear more from them actually. So there are many situations in which one might consider trabeculectomy or trabeculectomy in association with lens extraction, and I'm quoting two studies which came out in 2008 and 2009 from Hong Kong, and I think they've led the way to some extent in publishing literature and comparing between two groups of patients. So the first study was, they compared phacotrabeculectomy with adjunctive mitomycin C, and they found that it might be marginally more effective than phacoemulsification alone in controlling IOP in medically controlled CACG eyes with coexisting cataract actually. And you can see over there that's the effect of phacoemulsification on intraocular pressure long term at 24 months. And these two lines are phacotrabeculectomy. The bottom line includes all cases, and this center line includes those patients that had hypotonia actually. And then in another study, they pointed out that even in medically uncontrolled CACG eyes with coexisting cataract, they found combined phacotrabeculectomy with adjunctive mitomycin C to be more effective actually. There was a third study that came out after collating all this data, and I think Shushmita pointed out this study, but I'm just talking a little bit different about it. And they mentioned that when they had two groups of patients, one with that underwent phacoemulsification and the other combined phacotrabeculectomy, these were the pre-op and this is the post-op pressure, and with combined, this is the pre-op pressure and this is the post-op pressure. So you can see that there is an effect both of phacoemulsification and combined surgery at 24 months actually. And you can see that there is a reduction in the pre-op medications. However, the reduction in pre-op medications is much more with combined phacotrabeculectomy than with phacoemulsification alone. So I created some pathways or algorithms because this is what happens when different types of patients come in front of you, and you need to figure out what you're going to do today and what you're going to do for the patient 3 years and 5 years and 10 years hence actually. So you have, let's say, a 65-year-old lady that comes with more than 270 degrees synovial closure in the right eye and 200 degrees synovial closure in the left eye. The intraocular pressure is 20 millimeters of mercury in the right eye and left eye, and the optic disc shows a vertical cup disc diameter of ratio of 75% in the right eye and 65%. With glaucomatous damage, the visual acuity is still fine actually. So as I think all of us would agree, we plan to do a laser PI in the right eye and target for low teens intraocular pressure. And as Vinay pointed out before me, we follow up lifelong. But let's say 3 years later, because of not being able to predict whether the laser PI is going to work to control intraocular pressures over long term, 3 years later, the intraocular pressure on 3 medications is uncontrolled, there is progressive disc damage, and then you might wish to plan for glaucoma surgery. And if there is a cataract, you might wish to plan for combined surgery. And the left eye, we would also plan for laser peripheral iridotomy. And if at 5 years the intraocular pressure is well controlled with, let's say, 2 topical medications and no progressive damage, then we may not like to do anything more for this patient actually. Here is a patient that presents with intraocular pressure of 50 millimeters of mercury in the right eye and 20 in the left eye. The right eye has mild corneal edema, the peripheral anterior chamber depth is non-existent, and pupils are mid-dilated, and the iris is boggy and edematous. So this patient, you're going to use topical drops as you're going to try and reduce the intraocular pressure as much as possible. You wait for the corneal edema to clear, and as soon as possible, you aim for the laser iridectomy. And if that doesn't work, then you might consider a laser iridoplasty actually. You watch for a drop in intraocular pressure, check for optic disc status, and after that, you would assess for further medical management or the need for surgery. You have a patient here again with intraocular pressure of 45 millimeters of mercury in the right eye actually. So the right eye has got classical PACG, the cornea is clear, but there is 90% discoloring. You know, you get patients with 45 and 50 millimeters of mercury where the cornea is edematous, and you can get a similar patient where the cornea is all clear actually. So the patient is already using pilocarpine, beta blockers, alpha agonists. The right eye angle is completely closed. The right eye vision is 6/9 and has some degree of nuclear sclerosis. So you start the patient on topical steroids because you want to quieten the eye a little bit. At this pressure, you know the iris is going to be very boggy, and you ensure compliance. See what happens. If you're able to quieten the eye as soon as possible, you may wish in such a patient to plan for combined surgery actually, and you may give preoperative mannitol if necessary actually. And when you're doing cataract surgery, please remember that ideally you should only be using 2.2 millimeters because there are many, many advantages, and you're dealing with an extremely shallow anterior chamber, and the great challenge of doing combined surgery and cataract surgery is the shallow anterior chamber. And this is another patient who comes with an intraocular pressure of 45 millimeters of mercury. The anterior chamber depth is just 2.2 millimeters. The lens thickness is 5 millimeters. Remember, the lens thickness in most of these patients is more than 4.5, and it reaches nearly 5 millimeters in many patients actually, which means that the lens is going to be thick, and you can sense it when you're doing the cataract surgery actually. So the axial length is 21.85, which is near normal, which is what one of my colleagues pointed out, that it's not necessary to get hypermetropic patients that go into. The axial length is only marginally less in patients that present with primary angle closure glaucoma. So you have 360 degrees closure, and the patient is not on any medical treatment actually. So the vision is 6/6, and there is a scenario that one, there is no cataract, and there is another scenario where the vision is 6/24 and there is a cataract in the right eye actually. So you could, there are people who might wish to do a clear cataract extraction, clear lens extraction, or a cataract in such a patient. But let's say if the post-operative intraocular pressure is 25 millimeters of mercury, you treat with medications, and if it's uncontrolled, then you might still have to go for a trabeculectomy. Or you might just start with medical treatment and trabeculectomy, and then see how it goes. And if the intraocular pressure is well controlled, then that's fine. There are patients with trabeculectomy who may not be successful. You could have uncontrolled intraocular pressures after that. You could have progressive disc damage after that. And then in such a scenario, you might wish to do a lens extraction actually. So, or you might wish to do a combined surgery at the first go. So this is a video about combined surgery, and I think I'm going to go to the next slide, but there is really nothing much different in a patient that we're doing this, except that if you use the Kelly sponge, please remember that there are peripheral anterior synechia, so don't drag the posterior lip of the sclera too much, because if you do, then that means you're going to separate the root of the iris at the area of the peripheral anterior synechia, and that could cause some bleeding actually. Otherwise, I don't think there is too much different in this, except for the precautions that you have to take while doing cataract surgery, which I'm sure Dr. Pandav is going to talk to you about actually. So this is a case, we have a 60-year-old male, diabetic and hypertensive. The right eye vision was hand movements, and the left eye was 6/6. The right eye had chronic angle closure with 360 degrees synechial closure. Intraocular pressure was 44 millimeters of mercury when he came with 4 topical medications actually. The anterior chamber depth was 2.63, and the lens thickness in the right eye was 4.75. He underwent combined surgery. At 3 weeks, the intraocular pressure was 50 millimeters of mercury. So you have a combined surgery. You remove the lens, and you've done a trabeculectomy. And this has some relevance to what Dr. Ramanjit pointed out, that the intraocular pressure reducing efficacy is perhaps more when trabeculectomy is done alone actually. So this is something that all of us need to be aware of. In spite of doing 2 procedures that are supposed to reduce the intraocular pressure, you still have elevated intraocular pressure, and that can happen. Even with just pure lens extraction, there is a small percentage of cases that end up with elevated intraocular pressure actually. So we then did needling, and the patient has done quite well. And this is the photograph of the patient, and you can see, if you take a look at the right eye, you'll see that there is sufficient reason to do surgical procedures to reduce the intraocular pressure. So I think I'm going to end here. The advantage of combined surgery is that you are adhering to the principles of dealing with glaucoma surgery, and you're removing the lens, and both of them seem to offer a significant advantage, but I think more long-term studies will be required if we have to move further to resolve this issue, especially for Indian eyes. Thank you all.